Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician, and your host for today. I'm very excited to talk to today's guests, Dr. Mariam Iqneibi, a pediatric dermatologist, and Dr. Jessica Trygier, a pediatrician in primary care here at Cincinnati Children's. Today's discussion is a consult on eczema, or atopic dermatitis, a condition that most of us primary care docs see just about every day. So I'm excited to learn more about how we can manage this better for our patients. So first of all, Jess, Mariam, welcome. Thanks for joining us today.
Thanks so much for having us.
Yes,
it's a pleasure to be here.
And I'd like to start by having you guys introduce yourselves, some of your background, your training, when you came to Cincinnati Children's, any clinical interests, outside interests.
Sure, I can go first. So I'm Dr. Jessica Trygier. I am a primary care pediatrician in our Pediatric Primary Care Center at Cincinnati Children's. I did medical school at the University of Cincinnati and did my residency training here at Cincinnati Children's. So I'm a big-time Cincinnati fan. Outside of, obviously, the plethora of diseases that we get to deal with in primary care, I'm really passionate about prevention for our patients and then also some medical education work as well.
Excellent. Welcome, Jess. Mariam?
So I am a pediatric dermatologist. I did medical school at Jordan University of Science and Technology, and then I did residency in Qatar, finished there, and then I actually did my fellowship here at Cincinnati Children's, and I've stayed on ever since. And outside of obviously interest in inflammatory skin disorders, I do have an interest in neonatal skin disorders as well, and contact dermatitis is a big passion of mine.
Wonderful. And welcome to you both. I'd like to start today just by getting some background on eczema. As I said, it's something we see almost every day, and we all learned about it in medical school, the pathophysiology of it. But just to get some baseline knowledge, can you guys talk a little bit about what eczema is, what the causes are, any related conditions?
Yeah, absolutely. So eczema or atopic dermatitis, like you said, is incredibly common. Somewhere between 10 and 20% of kiddos are going to be affected by this. Luckily, the natural history of the disease is that most kids get better. So about 70% resolved by puberty, about almost half by the time they're school age. So that is one great thing about it. However, it is a chronic relapsing condition. And I think a lot of us think about it as just a skin disorder, but we do know that it has lots of other quality of life effects as well. So effects on sleep because of itching, effects on attention because of itching, poor wound healing, which can, impair growth over time, and other physical manifestations that can cause issues with self-esteem, mood, bullying, those kinds of things. When we think about what causes eczema, we think about kind of two things. One is that skin barrier is disrupted, right? You have this dry, flaky skin, and so it's not protecting us very well from the outside world, which is the big job of the skin, obviously. And then you get this cascade of inflammation and inflammatory changes in the skin, which further exacerbates that disruption in the skin barrier.
And as far as like age of onset, is there an age we typically see it start to emerge, and how does it change over time?
Yeah, great question. So we think that, typically we see it very commonly in the infancy and toddler age range, but it can be onset later on in life. Even adults can sometimes have a first onset of eczema, but most commonly it's in that like infant and toddler stage that we start to see it come up.
And what I've typically seen in my practice is as an infant, it's more kind of either whole body or on the trunk. And then as they get older, it migrates more to that, flexural surfaces that we all learn about. Is that accurate? Is that typical? Is that what you guys have seen?
Yeah, absolutely. I'd also add that infants tend to have it a lot of times on the cheeks as well.
Yeah.
And then I think the thing that can be tricky about eczema is it can look very different on different skin tones as well. So when we think about patients with lighter skin tones, it tends to be more erythematous, dry, pruritic papules and patches. And like you mentioned, in the younger kiddos, oftentimes on the extensor surfaces, and then the older kiddos, the flexural surfaces, versus in patients who have darker skin tones, oftentimes it'll look a little bit more hyperpigmented or violaceous or gray even. And then you can also see associated lichenification. So sometimes you can have really intense lichenification and it doesn't really look like standard eczema just because of how chronic the inflammation has been in that area. And then sometimes if there's a lot of overlying excoriation, you can see weeping, crusting, those kinds of things as well. So it can look very different depending on the age of the patient, how severe it is, and how long it's been going on.
And what about triggers? What kind of things do we know can make eczema worse or can bring it on?
Yeah, that's a good question. So eczema is multifactorial. So there's so many factors that contribute. Genetic factors, obviously having a predisposition towards that T helper 2 pathway that we know causes eczema, asthma, nose and eye allergies, but the environment as well. So we tend to notice a lot of our patients tend to flare up during winter. That dry winter weather contributes. When you have an impaired skin barrier, anything can get into the skin and trigger an inflammation. So exposure to irritants, exposure to fragrances, a lot of things can just sort of flare up your immune system. So there's not really one trigger that can cause eczema. It's dependent on so many things in your external environment as well as your genetics.
And the question I get a lot is about diet and food. Do we see an
Yes.
association between certain food exposures or food allergies and eczema?
That's a good question. So, eczema is not typically caused by food. So, when we think of food allergy, when we say allergy, usually that means a true allergy, and that's like a type 1 hypersensitivity reaction. And that's usually associated with hives, shortness of breath, facial swelling, things that we don't really see in eczema, which is mainly a T helper 2 pathway, so not a true allergic response. So, what I always tell patients is that you have an increased risk of developing food allergies, but in most cases, food allergies are not the cause of your eczema. It's a multifactorial component. And I think it just stems like from the frustration of families wanting to find that one cause for their eczema. And fortunately, I tell them there's no one cause, and it's actually quite dangerous because I see it a lot. I'll see kids who come to me who parents have eliminated all sorts of essential nutrients in their diet, and they're depriving them from foods that are essential for their growth in such a critical time. And in addition, they make them actually more at risk to develop allergies later on, because when you're depriving them from these foods early in life, when their body is just trying to get introduced and getting to know all sorts of different foods, you're more likely than not, if you're to introduce them later on, they'll actually develop a food allergy because their body was not exposed to that food early in life.
And a question that comes up a lot in infants is, in breastfeeding mothers, the mom's diet.
Mm-hmm.
I think you probably have a similar answer, but it is a question I get asked a lot. So do we know anything, or is there any expert recommendations on mom's diet when she's breastfeeding with eczema?
No recommendations. I mean, unless they are noticing specific foods that every time, mom ingests something and then the baby gets triggered, you can look into it, but more often than not, it's not associated. So I do not recommend going down that rabbit hole.
That is helpful. Gives us a little more ammunition when we're having those discussions. Thank you. What about related conditions? We hear about the atopic triad. Can you guys talk a little bit about that? Other things we may see running alongside eczema?
Yeah, for sure. So kids who have eczema are more predisposed to allergic rhinitis, allergic conjunctivitis, as well as asthma. We think about those three as kind of that atopic triad. So those things are definitely associated.
Okay.
I'd also add eosinophilic esophagitis.
Mm-hmm.
Very important. I always ask parents if they notice their kids, and I always check their weight, their growth, and check if they are eating well. They're tending to have a lot of reflux, because then we do have treatments that can treat all of those conditions.
Mm-hmm.
So really important to check and ask for that.
Great. And whether this is brought to us as a specific visit, as the question at hand, versus something that comes up at a well visit, what are some red flags we should be looking for or asking about when we're taking a history?
So red flags with eczema. So first of all, things that would concern me is that if this eczema is widespread, if it is persistent, if it's not responding to topical therapy, if we're having a lot of hospitalizations and ED visits, a lot of superimposed infections, that would make me lean more towards seeing the patient as soon as possible and starting on systemic treatment, because then obviously it's not only associated with high risk of life-threatening complications or complications that can be detrimental to their quality of life. But so those are things that I would tend to want to look for.
And I'd also say if you're ever not sure that it's 100% eczema, there are lots of mimickers of eczema out there. And so it's never wrong to enlist the help of a dermatologist for diagnosis. There's no shame in that.
And what are some of the things that can mimic eczema?
So a lot of things. So most commonly what I tend to see is seborrheic dermatitis. That's that cradle cap. So when that occurs on the scalp and the flexural areas, especially in infants, it's not localized just to the scalp. You can also find it in the neck folds. You can find it in the axilla. So that is a good mimicker for atopic dermatitis. And sometimes it's hard to differentiate because they commonly occur together from both. Contact dermatitis. So I tend to think of that when they say that eczema is localized. They're like, eczema is only happening on the hands or only around the eyelids, then that is very unusual locations just to have eczema. Then I would investigate further. So those are some of the conditions. Nummular eczema is also another common type of eczema that's a little bit, clinically different, looks different than atopic dermatitis, looks sort of like coin shaped, lichenified, itchy plaques. But yeah, those are some of the more common conditions that can be misdiagnosed.
Yeah, and that nummular eczema is always tricky
Mhm.
between, is it nummular eczema, is it ringworm, is it impetigo, and any pearls on how to differentiate those?
So if you are not sure, refer to a dermatologist. And usually sometimes we have a hard time. So for example, differentiating it from fungal infections, because they also look round, scaly, we do fungal cultures. So I would usually treat, and if I am not sure, I would investigate further, whether that is with cultures, whether that is with a biopsy. Some of our more scary conditions that can be misdiagnosed as eczema is a condition called mycosis fungoides, which is a cutaneous T-cell lymphoma. And that looks similar to eczema, but that's usually when we think of that, we think of patients who are not responsive to therapy or they're having just widespread eczema in unusual locations, in a bathing suit sort of distribution, then we tend to biopsy those patients. So whenever not sure, refer. We're happy to do further investigations.
Great. So I think we've talked a lot about history, and you've mentioned exam kind of early on, like what it looks like and where it is. Really, the big question that we often have is management. When or what are our first steps when we're suspicious the child has eczema? What do you guys recommend? First line, second line? Does it depend on severity?
Yeah, absolutely. So the first thing I want to talk about is prevention, both primary and secondary prevention. In terms of primary prevention, so we're talking about even preventing that very first eczema flare. There's some small but good studies out there that show that patients who are at risk of developing atopic dermatitis, so one of their first degree family members has an atopic triad disease, whether that's asthma, eczema, or allergies, proactive application of a moisturizer starting at around 3 weeks of age decreases the risk of getting an atopic dermatitis diagnosis at 6 months of age by 50%. So if you think about like how many kiddos we see diagnosed with eczema, if we could maybe delay 50% of those diagnoses, obviously we need like longer term studies and some more robust clinical samples. But I think this is really exciting emerging evidence that we might be able to prevent some of this for a lot of kiddos. And then in terms of secondary prevention, like we talked about, eczema, I think it's really important when you're talking with families is to frame it as a chronic relapsing disease, because I think a lot of times families get this conception that, okay, I had this rash, we're going to treat it once, it's not going to come back. And so I think like really framing that in your discussion about how we're going to try to prevent the flares, but expecting that they're going to come can give kind of that reassurance that like when the flares do come, it's not a failure on the parent's part. It's not, nothing that the kid did or those kinds of things. But it's just something that we kind of expect with the course of atopic dermatitis. So in terms of our best evidence for kind of secondary prevention, so preventing those flares, strong skincare routines, focusing specifically on moisturization and avoiding triggers, and then proactive application of topicals are some strategies that can really reduce the incidence of flares.
And then for those milder cases, what would you recommend as a first set of topicals, creams, lotions? When do steroids become involved?
Yeah, absolutely. So I think if you have a really mild, very localized area, totally reasonable to just start out with a moisturizer. And we can talk about, when we think about moisturizers, there's a wide variety of them, all the way from lotions, which are those thinner moisturizers, all the way to ointments. So your Aquaphors, Dermaphors, Vaselines, cocoa butter, shea butter, those kinds of things. We tend to lean towards more the thicker ones, but there's actually some pretty good evidence out there that the best moisturizer is one that families can adhere to. So whatever you can get to put on your kid every day, twice a day is ideal, but if you can only get it once a day, I think that's a reasonable approach as well. Doing that regularly is going to be kind of the foundation of the very first start of eczema management. And then starting kind of on the lower side of steroids, so think about your hydrocortisone 1%, 2.5% for those small areas that are just a little bit red and bumpy is very reasonable.
And then what about the role of baths? I feel like that guidance has changed over the years. What should we be telling parents about how often they should bathe the children, temperatures of water, when to apply or how to apply the lotions followed by the emollients after that? I mean, what advice would we give on bathing?
Yeah. So in terms of bathing, the things that I like to talk about is lukewarm temperature. Okay. So no cold, no scalding hot, because we know that hot can also dry the skin out more so. Using fragrance-free products when you're in the bath. So trying to avoid things that are scented. And you have to be careful about unscented, because unscented can actually mean that there's a scenting agent and a descenting agent. So you actually want to look for a fragrance-free when you're picking out bath products, just to help reduce that possibility of drying, because all of our fragrances are alcohol-based. And then the other thing about bathing is, when they get out, instead of wiping them down or applying a lot of pressure, which can kind of harm the skin barrier if you think about the force applied, that really try to do a pat down and leave them just a little bit damp, and then go in with, if you're using a topical ointment first, and then covering it with that thick moisturizer is ideal. In terms of frequency of baths, my approach is usually bathe your kid when they're dirty. There's no need to say, oh, you have to bathe every single night or you have to bathe only once a week. I think, you can kind of take an individualized approach to what your kiddo needs there.
And then as far as like other kind of low-level medications, how about the role of like antihistamines for both itching, but also, I have some kids who their eczema flares not in the winter, but in the spring. So what role do antihistamines play?
Yeah, that's a great question. There's actually some really great evidence that antihistamines do not actually treat itch and eczema. So we don't recommend them routinely. Now, if you're treating a comorbid like allergic rhinitis or something like that, absolutely reasonable to do that. The one exception I would say is you can use Benadryl for sleep. So you're using it more for the sedative effects in the setting of itching rather than the itching control. So I think that's something that's commonly misunderstood. The best evidence for controlling itch is really those topical steroids.
Okay. And if we try the over-the-counter 1% hydrocortisone or the 2.5%, when should we think about escalating to a higher potency steroid? And how would we use that?
Yeah, I think as soon as you're not getting good benefit after a week or two, feel free to escalate your steroid strength, right? I think one of the really tricky things about steroids is that there are just so many available, and depending on the vehicle, so whether it is an ointment or a lotion or a cream, and depending on the strength, the same name of medicine can mean vastly different things. So I think my best advice is find a resource that you use and have your typical ladder of how you escalate, and then utilize that, because otherwise it can be super confusing.
And then, Mariam, one thing that always gets a little tricky is eczema on the face.
Yes.
So, we always want to be more careful with the skin on the face.
Mm-hmm.
What are your recommendations? Like if they have eczema, whether it's on the cheeks or on the eyelids, those kind of things?
So eczema on sensitive areas, what we call thinner skin areas, like the face, the underarm areas, the groin, you want to typically aim for a low potency, low strength sort of steroid. So that's your hydrocortisone 2.5, that's your triamcinolone 0.025%. That's safe to use in those locations. Or a really nice alternative is a steroid-free option, so a steroid-sparing option. I like to give that for those sensitive areas as well. And those are going to be your calcineurin inhibitors, your Protopic, your Ilidil, your Eucresa. There's so many options right now out there for topical steroid-sparing agents that you could use in those areas. Higher strength steroids, medium potency, you tend to use it on the body. And you can be more aggressive on the hands and on the ears. Those are thicker areas of skin. So with that, even if you were to use a class 1 steroid, super potent steroid, that's fine for those areas. Of course, in a limited time. So you wouldn't want to use it for extended weeks on it. I would say on average, at least consecutively for about 2 to 3 weeks. It's safe for those areas.
I never would have thought of the ears as a thicker skin area. So the steroid sparing creams, I mean, you mentioned Protopic, Elidel. I think as a general pediatrician, I always look at those as a little more higher level, maybe, would refer to a dermatologist before doing those. Do you think that is something that a primary care pediatrician could do?
Definitely. I think they are a really nice option. And I think that there's a lot of, preference now by families to, when possible, avoid using steroids. And I really like to give these options, and they're very safe options. The only thing that I would caution providers to warn families before prescribing them is there is a black box warning on them. So you do want to give families a heads up. And usually what I explain to the families are these black box warnings are not for the topical medications. They were for the oral medications, and they were given for a completely different disease under completely different circumstances for adults. So sometimes when they just have that heads up before getting the medication, they're more willing to use it.
And as far as using those, are they typically used more for flares, or is that more of a long-term medication?
So you typically use them for flares, and you can use them for maintenance treatment. So sometimes I like to use them to break off the steroids, especially if I know that they're going to be using steroids for quite a long time. I do want a little bit of a break in between with the steroids. So what we can do is I like to do like my 2-week approach. So I'll do 2 weeks of like a medium or strong potency steroids twice a day. And then I break it off with 2 weeks of a non-steroid twice a day. And then I feel like families are more, willing to comply when they know that there's that break in between with steroids.
And when we have a kid in the office whose eczema just seems a little more severe or appearing a little differently than we would expect. I guess what I'm getting at is complications with eczema.
Mm-hmm.
Infection is kind of the one I see the most often. What kind of advice do you guys have as far as when to suspect infection, superinfection, and how to treat it?
So infection is a common complication because you're having a defect in the skin barrier. So what are the most common superimposed infections that I tend to see in the clinic are impetigo. So that's that yellow crusting that you're going to see typically on the face or on the mouth, can be found in the groin area. Whenever you see that yellow honey colored crust, if you suspect it, you have to swab it. And preferably to swab not on the crust itself. You have to get under the crust in order to evaluate it properly. So that's one thing. Herpes, simplex virus, so eczema herpeticum, it's very, you should have a high alert out for it. So when you see those punched out ulcerations, those vesicles with an erythematous border, that is something that needs to be treated urgently. So if you suspect it, swab. It's never wrong to swab. Yeah, even if I have a low suspicion, it's pretty non-invasive, and you can save the child from so much pain, so much future complications. Eczema coxsackium is another common complication I tend to see with eczema. Molluscum, because you're having a defect in the skin barrier. So it's very common to see molluscum overlying the areas where the kiddo has eczema.
I see that a lot.
So those are things that you want to keep in mind. And of course, if you're having a defective skin barrier, anything that comes in contact to the skin will trigger immune system. So over time, I notice a lot of these kiddos end up having contact dermatitis to a lot of different products, irritants, and a lot of allergic contact dermatitis as well to products, just because their skin barrier is impaired. These allergens are always getting in and always riling up our immune system.
And as far as like non-pharmacologic treatments, we've mentioned the moisturizing, we've mentioned the baths. How about things that we hear about like wet wraps or bleach baths? What is the evidence on those? What are your recommendations?
Yeah, absolutely. So thinking about doing wet wraps and bleach baths, the hard part is that both of these have been pretty hard to study. And so there's not really great high quality evidence, but I think expert opinion, and I think many of us in private or in general practice see a lot of benefit from these interventions. And so wet wraps are one of the things that I go to when I'm seeing a kid in the office who has a severe flare. Sometimes maybe they've been out of their medicine for a little while or that kind of thing. It can be kind of a jump start to really get good control of their eczema. It can also be super helpful when the kids are incredibly itchy, because we talked about how antihistamines aren't really as effective as we once thought they might be. How I usually talk about doing wet wraps with my families is, you're going to take that lukewarm bath with your unscented products. You're going to pat them down, leave them a little bit damp. You're going to go ahead and put that topical steroid on the areas that are flaring. So if that's the whole arm or if that's the trunk or wherever it is, cover the whole body in your thick moisturizer. And then you're going to put a damp substance on whatever area is flaring. So if it is just the arm, you can use a sock and cover the arm in a damp sock. Or if it is the whole body, you can put on like a pair of footy pajamas that have been, damp, not soaking wet, but damp. And then put on a pair of dry pajamas. And then sometimes they need an extra blanket or something like that. And you can do that for a couple of days, up to like a week or so. And that can sometimes a really intense treatment because you're getting that extra moisturization essentially because of that damp layer to really help rescue that eczema. I think the biggest things to watch out for is you want to make sure that your wraps aren't constrictive, so you're not cutting off blood flow. You want to make sure that you're not getting any skin maceration. There is a risk of like folliculitis just because you are increasing that hydration so much. So those are the big things to watch out for, but not commonly seen. And then I think the other really important piece of this is when you take that off in the morning, go ahead and get aggressive with your moisturizer again for that kind of intensive treatment.
And what kind of feedback do you get from parents or from the patients themselves with their experiences with the wet wraps?
I'll be honest, there are some kids that don't like it, right? I think that's something we see commonly in pediatrics across the board. But I will tell you that I've had families that it's like, this was terrible, and 2 days of this, and oh my goodness, it has made such a tremendous difference. So I think, especially because, maybe it's going to be a little bit of a wait to get into dermatology and the kiddo's miserable, you can use these with the creams that you have at home already. It's nice to not have to go to the pharmacy and get something new or different. A lot of families really like that aspect of it.
And then bleach baths?
Yeah, bleach baths. So we think bleach baths work from both an anti-inflammatory and an anti-itch perspective. There's some mixed data out there about what they actually do for bacterial colonization on the skin, but essentially what you're going to do is make a 6% household bleach bath solution. And how I like to think about this is really you're going to do a 1/4 cup in a half full bathtub or a teaspoon per gallon of water. Like let's say if you have an infant who's in an infant bath, you're going to have them soak in this bath for about 5 to 10 minutes, rinse, pat dry, put on that moisturization. Oftentimes you're doing this once or twice a week, but that can be super helpful for families, again, to use things that they already have at home to kind of improve their eczema care and especially help with that itch.
That's the one that I tend to get parents to look at me a little cross-eyed like, really? But I've had pretty good experience with that for those kids with the full body flare, for sure. So we've talked about a lot of the tools that we as general pediatricians and parents have at hand. Mariam, are there any other systemic options that we can either prescribe ourselves or our dermatology friends might be using?
So there's a lot in the field of pediatric dermatology right now, or in dermatology in general, for systemic options. So in addition to like the topical non-steroidal agents we mentioned, like the Eucresa, the roflumilast, the ruxolitinib creams, we have a lot of systemic options. So we have our conventional therapies, which were our methotrexates, our cyclosporins, and these work very well if parents want an oral option, especially cyclosporin. It's quite fast acting, so a quick rescue therapy. I would prefer these over oral steroids.
Mm-hmm.
Oral steroids are a big no-no for atopic dermatitis. The reason is, will they work? Yes. Will you get a rebound like you've never seen before? Yes. So never oral steroids. We have a lot of conventional treatment options that we can use as rescue therapies, particularly the cyclosporin, which is fast acting, and we can also use methotrexate for parents who want a oral treatment for their child's eczema. The other options that we have that have really changed the game are our biologic therapies. These are targeted therapies, so they act on a specific chemical or interleukin that causes atopic dermatitis and itch, and it really provides tremendous relief. Not only does it help to treat eczema, but it also helps to treat a lot of the comorbid conditions associated with eczema. So very useful for kids who have eczema, asthma, nose or eye allergies, and even if their eczema is mild, but you want to give them something that's basically a 2-for-1. These are some great options. The other options that we have available out on the market are our JAK inhibitors, which are small molecule of therapy. So these are our abrocitinibs, our upadacitinib. They work great. They are wonderful, but they do need lab monitoring, unlike our biologic medications. And another nice option I really like to offer families, especially if they are, they don't want to try any of those conventional medications or biologics or JAK inhibitors, is phototherapy. Works wonderful. It takes quite a long time though. So phototherapy is a light-based therapy that acts on a specific wavelength of light within a range, and it actually suppresses your immune cells in the skin. So we use it for a lot of our inflammatory skin conditions. We use it for eczema, we use it for psoriasis, and it's pretty quick. It acts, it only needs like 1 to 2 minutes in the phototherapy booth, which is sort of like a vertical tanning bed. They only need to do it 2 to 3 times a week. But the problem is it takes quite a while to see an effect. So I do tell parents to be a bit patient. And unfortunately, not every location carries a phototherapy and narrowband UVB phototherapy booth. So you are going to have to search for a place that can offer that. And that is, convenient for families to go to 2 to 3 times a week. But yeah, also just briefly speaking about, non-conventional therapies that parents can do at home. In the summer, they can do something that we call helotherapy, which is sun-based therapy. So exposure to sunlight for 15 minutes during peak hours can really help with eczema. So sort of like that light-based therapy that we talked about, that phototherapy, but in nature, in the sun. And that's something that they can do by themselves at home.
And then kind of circle back to prevention. Jess, is there anything else that families can do in between flares to reduce the frequency of the flares?
Yeah, absolutely. So we talked about kind of those good skincare routines, avoidance of the irritants. The other thing that has some pretty great evidence is something called proactive application of topical steroids. So essentially what you do is on 2 consecutive days of the week, so typically this is easiest to remember on a Saturday or a Sunday for most families, is you put the topical steroid on the area that tends to flare. So let's say it's always the right AC fossa that is flaring. You put that on Saturdays and Sundays, and then that decreases the risk of flares over time. And in addition, and this can be a great selling point for families who are a little bit nervous about steroids, is it's been shown to decrease the amount of topical cream that you need long term. Because if you think about once your eczema flares, you're usually using steroids for a week or 2 to get it under control, versus if you can just do once a day application on those 2 like Saturday, Sundays, you're using way less cream overall. And that can be a nice way to keep kids comfortable.
Well, Mariam, Jess, thank you so much for your expertise today. I know I've learned a lot, and hopefully we can share that with our patients. For our listeners, today's discussion was guided by the Community Practice Support Tool on atopic dermatitis. You can find that on the CincinnatiChildren's.org website. And today's episode is available for CME. You can find a link to that in the show notes. Thank you guys, and have a good rest of your day.